Diabetes in the Pediatric Population by Michelle Dezizek, Brooke Johnson, Colleen Murphy, and Kate Donnelly. In 2013, the American Academy of Pediatrics recently released the first clinical guidelines for treating type 2 diabetes mellitus in pediatrics. Currently in the United States, approximately 1 in 3 new cases of diabetes mellitus diagnosed in patients younger than 18 is type 2, with a disproportionate representation in ethnic minorities, especially among adolescents. This trend is not limited to the United States, but is occurring internationally as well. Some risk factors for type 2 diabetes are being overweight, a family history of diabetes, being female, specific ethnic groups such as American Indian, African American, Asian, and Hispanic. Most children with type 2 diabetes are diagnosed at the start of puberty. Some causes of obesity are unhealthy eating patterns and lack of physical activity. There is also an inherited tendency, and rarely a hormonal problem or other medical condition. The risk of type 2 diabetes in children appears to be associated with excess abdominal weight. This obesity pattern increases the chance of insulin resistance and the risk of type 2 diabetes. According to the American Academy of Pediatrics, children and adolescents, which are defined as patients under 10 and under 18, respectively, have an increased risk for type 2 diabetes because for obesity, strong familial history of type 2 diabetes, substantial residual insulin secretory capacity at diagnosis, and insidious onset of disease, demonstrating insulin resistance and lacking evidence of diabetic autoimmunity. Diabetes is a group of diseases marked by high levels of blood glucose resulting from defects in insulin production, insulin action, or both. Diabetes can lead to serious complications and premature death, but people with diabetes can take steps to control the disease and lower the risk of complications. Type 1, previously called insulin-dependent or juvenile onset, accounts for approximately 5% of all diagnosed cases of diabetes in adults, and type 2, previously called non-insulin dependent or adult onset, accounts for 90 to 95% of all diagnosed cases of diabetes in adults. Type 2 diabetes is increasingly becoming diagnosed in children and adolescents. Type 2 diabetes mellitus is due to 3 possible defects: insulin resistance in muscle and adipose tissue, beta cell dysfunction, and excessive hepatic glucose production. Research has shown that by the time type 2 diabetes is diagnosed, at least 50% of beta cell function has been lost. At the same time, the liver produces more glucose than the body can use, causing a further increase in plasma glucose levels. Insulin is then needed to shut off the liver glucose production. With less circulation, insulin, and marked insulin resistance, the liver continues to make glucose in an unrestrained manner. Some symptoms of type 2 diabetes are increased hunger or thirst, unexplained weight loss, frequent urination, fatigue, blurred vision, heavy breathing, dry mouth, itchy skin, or numbness and tingling in the hands and feet. Approximately 215,000 Americans younger than age 20 have diabetes. Most cases of diabetes among children and adolescents are type 1. However, as obesity rates in children continue to rise, type 2 diabetes, a disease that used to be seen primarily in adults over age 45, is becoming more common. The American Academy of Pediatrics has issued the following guidelines in dealing with type 2 diabetes. Ensure that the insulin therapy is initiated for children and adolescents with type 2 who are ketotic and in diabetic ketoacidosis, and in whom the distinction between types 1 and 2 diabetes mellitus is unclear. Initiate a lifestyle modification program including nutrition and physical activity, and start metformin as the first-line therapy for children and adolescents at the time of diagnosis. Monitor hemoglobin A1C concentrations every 3 months and intensify treatment if treatment goals for fingerstick blood glucose and hemoglobin A1C concentrations are not being met. Advise patients to monitor fingerstick blood glucose concentrations in patients who are taking insulin or other medications with a risk of hypoglycemia, are initiating or changing diabetes treatment regimen, have not met treatment goals, or have intercurrent illnesses. Incorporate the Academy of Nutrition and Diabetics Pediatric Weight Management Evidence-Based Nutrition Practice Guidelines in their dietary or nutrition counseling, and encourage children and adolescents with type 2 diabetes to engage in moderate to vigorous exercise for at least 60 minutes daily, and limit non-academic screen time to less than 2 hours a day.
Management of type 2 diabetes in children and adolescents with diet and exercise. Consuming more calories than one uses results in weight gain and is a major contributor to the increasing incidence currently seen with type 2 diabetes in children and adolescents. According to the American Academy of Pediatrics, The current literature that exists today is inconclusive about a single best meal plan for patients who have diabetes mellitus, and there are limited numbers of studies that exist that specifically address the diet of children and adolescents with type 2 diabetes. Although there is not a large amount of studies that have been conducted on children with type 2 diabetes, there are numerous studies that exist that have focused on overweight children and adolescents because the great majority of children with type 2 diabetes are obese or overweight at the time of diagnosis. The American Academy of Pediatrics recommends that physicians should refer their patients to a registered dietitian who specializes in the nutritional needs of children and adolescents with type 2 diabetes. The American Academy of Pediatrics also suggests that clinicians should incorporate the Academy of Nutrition and Diabetes Pediatric Weight Management Evidence-Based Nutrition Practice Guidelines, which describes effective, evidence-based treatment options for weight management. The American Academy of Pediatrics suggests that clinicians should encourage children and adolescents to follow the Academy of Nutrition and Dietetics recommendations for maintaining a healthy weight to promote health and help reduce obesity in this population. Regardless of what meal plan is prescribed for the child or adolescent with type 2 diabetes, some degree of nutrition education must be provided to maximize adherence to the program and to achieve maximum results. The education provided should encourage patients to follow healthy eating patterns, such as consuming 3 meals a day with planned snacks each day. Children and adolescents should be encouraged to not eat while watching television or while using computers. Using smaller plates should be encouraged when eating to make portions appear larger. Common dietary recommendations to help reduce caloric intake and promote weight loss in children include eating regular meals, reduce portion size, choose calorie-free beverages except for milk, limit juice to 1 cup per day, increase consumption of fruits and vegetables, consume 3 or 4 low-fat dairy products per day, limit intake of high-fat foods, limit size and frequency of snacks, reduce calories consumed from fast food meals. Physical activity is a large component of weight management and for the prevention and treatment of type 2 diabetes. The American Academy of Pediatrics suggests that clinicians encourage children and adolescents with type 2 diabetes to engage in moderate to vigorous exercise for at least 60 minutes daily for the reduction of BMI and improved glycemic control in patients with type 2 diabetes. Adherence to an exercise regimen may be improved if clinicians provide the patient with a written prescription to engage in physical activity. It is most helpful if the clinician recommends an individualized approach that can be incorporated into the child or adolescent's daily routine and is tailored to the patient's capabilities and preferences and also recognizes the family's circumstances. Together with the patient and the patient's family, the clinician should determine an individualized plan that includes specific goals to help reduce sedentary behavior and increase physical activity. Patients should be encouraged to identify a wide variety of forms of activity that can be performed both easily and frequently. Patients should be encouraged to incorporate physical activities into their daily routine. Physical activity may be gained through either structured games and sports or through activities such as walking. Patients should be encouraged to restrict non-academic screen time to a maximum of 2 hours per day and to discourage the presence of video screens and television sets in children's bedrooms.
Treatments for type 2 diabetes. When diet and exercise do not work to control blood glucose levels, medications are then prescribed. Deciding on which treatments to use depends on the person's blood sugar levels, other associated health problems, and weighing the pros and cons to each medication, such as cost. A combination of different drugs may be used. A person will choose a blood glucose monitor that works best for them. Many different systems are available. The process is simple. First, the person must wash their hands, and then they prick their finger with the lancet. They place a drop of blood on the blood glucose testing strip, and within a few seconds, the results are received. When does a person need to test their blood glucose? They need to test their blood glucose when they are newly diagnosed. They also must test their blood glucose when symptoms of an abnormal blood glucose level appear. The blood sugar mnemonics for hypoglycemia and hyperglycemia are: cool and clammy, need some candy, for hypoglycemia. This may be due to skipping a meal or increased physical activity. Hyperglycemia, or hot and dry sugar high, could be due to not taking enough medications, being ill, or eating too much. Physicians will often prescribe metformin, also known as glucophage, which increases the body's sensitivity to insulin and then decreases the liver's output of glucose. If metformin cannot be used, alternatives are Januvia, Prandin, and Starlix. Other oral or injectable medications include the brand names Glucotrol, Diabeta, or Amaryl, which stimulate the pancreas to produce and release more insulin. Precose or acarbose blocks the action of the enzyme that breaks down carbs in the intestines. Insulin therapy may then be needed if oral medications are ineffective. Insulin is most commonly injected using an insulin pen. Long-acting, short-acting, or intermediate insulin is available. Brand names that are commonly seen are Humalog, Novolog, and Lantus. A mixture of different types of insulin may be prescribed to use throughout the day. The hemoglobin A1C is a blood test that is prescribed by the doctor to be done at least twice a year, at a minimum. The target result is a 7. Anything above indicates that the treatment plan must be altered in order to keep better control of the person's blood glucose. This test also helps to determine if a current therapy needs to be changed. Here are our references.